Okay. I am Dr. Felix Leung. I am at the West Los Angeles VA and UCLA. And this morning, I am interviewing Dr. Muthusamy and Dr. Thaker about their report on the anatomic location of Barrett's esophagus recurrence after endoscopic eradication therapy, development of a simplified surveillance biopsy strategy. I'm going to begin asking Dr. Muthusamy what was the background and the origin of the study, how it all got started.
Yeah, thank you, Felix. So, well, as you know, after endoscopic eradication therapy, there is a risk of developing recurrent Barrett's. And that risk can range from around 10 to 15% over time. It's higher when there's originally had high-grade or cancer, and lower if there was, for example, low-grade or no dysplasia. And what we've traditionally done is taken 4-quadrant biopsies in every centimeter throughout the entire treated region. So in patients with long segments that have been treated with 10 centimeters or so, you're talking 40, 44 biopsies. And these people come back every 3 months, usually in the first year if they've had high-grade or dysplasia. So you can see the enormous sort of path costs that can be generated. And it's sort of taking that many biopsies can certainly take a long time. And we were doing this sort of randomly. So we tried to see if there was a way we could look at where recurrences really occurred, and if we could sort of more intelligently sort of stratify and simplify our biopsy protocol.
So please tell us about how the study began and how the group got together to begin the investigation.
So our research group is the treatment with resection and endoscopic ablation technologies for Barrett's esophagus, or TREAT-BE. And it's a multi-center consortium that came about probably about 4 to 5 years ago that has sort of pooled their data on patients who have been treated with Barrett's esophagus and then looked at sort of multi-center outcomes over time.
Good. So Dr. Thaker, what were the main findings in the report?
Sure. So in about 455 original patients that underwent eradication therapy, over the study period, we found 50 recurrences that kind of met our final inclusion criteria. So out of 50 patients that had recurrence, what we did is we stratified them by whether there were recurrences at the site of a visible lesion, or if it was recurrences that only were found on the random biopsy. So we call those non-visible recurrences. Visible recurrences, and I stress this significantly, that's based on careful visual inspection by the endoscopist, looking for little islands, anything that looks like it's a potential culprit in taking a biopsy. Those should be dealt with the same way. We can see those, we can find those. It's those that are microscopic that we get on those random sampling protocols. So out of those 50 patients, we had 17 recurrences that were non-visible, meaning they were just found on biopsy, there was no visible lesion reported on endoscopy. Of those 17, we discovered that all of them were within 3 centimeters proximal to the GEJ, which for the purposes here, we use the top of the gastric folds, everyone agreed upon. 16 out of those 17 non-visible recurrences were within 2 centimeters of the GEJ. So when we looked at it a little more closely, recurrence of IM is one thing, but recurrence of dysplasia is really what we worried about. All dysplasia recurrences, which were 16 patients, every single 100% of those were within 2 centimeters of the GEJ. So now we've discovered, kind of in somewhat reflecting real world practice probably, that people biopsy the cardia a little differently, but we know the cardia is a hot zone for recurrence. Even in long segment Barrett's, recurrence tends to occur there. So for the purposes of this study, we define the cardia as biopsies taken either right below the top of the gastric folds or somewhat straddling the neo-squamous junction, the new Z line after eradication. So all of that were lumped to the cardia. And then if you add the extra 2 centimeters just above the GEJ there, 16 out of 16 patients with dysplasia and 16 out of 17 patients with any type of recurrence of any sort were within 2 centimeters or including the cardia. And so what that tells us is that biopsies very high up, more proximal to 2 centimeters, may be needlessly excessive. We may not need to do them because we found no cases of recurrence that far up. The average length, by the way, of Barrett's that were included in the analysis, The circumferential average was, or actually it's the mean is 4 centimeters, and the maximum was 6 centimeters. So if you take this together, we decided to come up with a biopsy protocol, which I'll mention in a few minutes.
So in short, most of the areas that, almost all of the recurrences that occur that are non-visible really just within 2 centimeters of the GEJ. And so that's when we decided that, and again, this includes all the, certainly there were some non-dysplastic recurrences and there were some, dysplastic recurrences as well. And the total number of patients that we looked at that had started this was, in excess of 400. So it was really about a roughly 10% recurrence
So
rate.
I'm curious, are all the colleagues in the group focusing only at the distal 2 centimeters of the esophagus from now on in terms of biopsying and follow-up of these patients?
Yeah, so our plan and kind of what we discussed in the discussion is based on this data, and now this kind of corroborates findings from an earlier study that suggests the distal esophagus and the cardia really are the hot zones. We propose a new biopsy protocol that our group internally has moved forward with standardizing and doing the same way. But it simplifies it significantly. So 4 biopsies, 4 quadrants, just the same, just below the GEJ, so about half a centimeter below. Not fully into the stomach, but just a little below. We're calling that cardia. The second set of 4 biopsies, straddling the GEJ, so really hitting that hot zone very hard. So right, you can use the squamous-columnar junction and go right across it. So that's 8 so far. And then 4 quadrants at 1 centimeter above the Z-line and 2 centimeters above the Z-line. And so again, random 4-quadrant biopsies. And as I stressed before, this is in addition to targeted biopsies of any visible lesion. So this does not negate that. But if you have no visible lesions, and you take our original C4-M6 Barrett's esophagus, we've now taken what could have been very many biopsies and reduced it to a minimum of 12. And based on this, you could reduce the number of biopsies, at least in our database, it would have reduced the number by 57%. So it would significantly have cut the number of samples you need to take.
So I guess one of these days you would like to see this new proposal adopted by other endoscopists who would do treatment for the, okay. What about for the average endoscopist who does upper endoscopy but do not necessarily do any treatment of the Barrett's?
Well, I think one of the things we're learning is that we really need to do a better job with our inspection of Barrett's mucosa, whether that's post-ablation or pre-ablation, as you're sort of suggesting here. And there's been several studies that out of Europe that show that that when someone who's referred for ablation from an outside center that was described as having no visible lesions goes to an expert center, a visible lesion is often detected, in fact, almost a majority of the time. So, and I think, if we're going to see these people every 3 to 5 years, it's a fairly short segment we're examining. It's worth spending a couple of minutes, I would say, and people have talked about Barrett's inspection times similar to colon withdrawal times, So I think that we need to slow down. It's not a large area, but really try to focus. And I think that one of the areas that our group and others are working on is to teach people exactly what the subtle findings are, both on high-definition white light and narrowband imaging, so that we can do a better job in surveillance.
So what should the take-home message be then, based on the findings for the audience or for the readers who will be reading the article?
Well, to kind of summarize, we understand that there's a lot of different protocols to remember with regards to Barrett's, and the goal here was to really simplify it. So the focus of this paper was, after eradication therapy, is there a way that we could decrease the burden of biopsies? Our paper showed that if you're going to take biopsies, the hot zone was really the GE junction, including a short distance into the cardia, and the distal 2 centimeters. And so if there's going to be any focus, really, that is probably where biopsy should be taken, because that's where the non-visible recurrence is, which is really the point of random biopsies, is to look for recurrences that are not found on a careful visual inspection with white light, HD, and narrowband imaging, which should still be done.
So this will certainly simplify the follow-up examinations.
Certainly, and there's been recent evidence that suggests even the surveillance intervals could potentially be lengthened. So we hope that taken together with needing less biopsies and maybe widening the surveillance intervals, if this is kind of prospectively validated, then it could significantly decrease the burden of surveillance after eradication therapy.
Right. Which will
Very
hopefully
good.
make these procedures shorter and less expensive from a pathology cost.
That's a very, 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 very useful approach.
Yeah.
Okay, thank you very much, both.
Thank you, Dr.
Thank you.
Great,
Appreciate
thank you.
it. Yeah, appreciate it.